stay in our course, Dr. Ahmed will challenge the theory. We need to have your outcomes. We need you to go home as enucleators, and you will do the job, I'm sure of that. So Dr. Ahmed will challenge the theory of yesterday by giving us some morning coffee, which is a morning quiz. Dr. Ahmed.
Thank you, Dr. Ahmed. Good morning, everybody. We will challenge the theory just to refresh your info. We presented yesterday. We have 20 MCQ questions. I need you to try to recall the information we presented yesterday.
I ask everyone to mark his answers. Yeah. I need every one of you to be able to score himself. I answered right answer in 5 out of 5, 10 out of 10, 9 out of 10. So mark your own answers and give a score for yourself and keep it for yourself.
Okay. With our first question for today, which of the following lasers has the highest water absorption coefficient? Which laser of the following lasers has the highest water absorption coefficient? So what do you think? Look, as Dr. Ahmed Atta yesterday mentioned in the mandatory physics of laser, every laser has its own fingerprint, and in order to understand how the laser works, every laser has its own wavelength, absorption coefficient, target chromophore, and optical penetration depth. For the wavelength of the holmium is 2100 nanometer. For the TFL is 1940. And so long you have shorter wavelength, the absorption coefficient is to somehow close to that of the water. So the absorption coefficient of the TFL is 4 times more than the holmium. So the answer is TFL. The next question, which of the following is true for laser inoculation? Steep learning curve with similar retreatment rates to tears, shorter operative time, size independent, cannot be done for recurrent blood outlet obstruction, not suitable for patients with coagulopathy. Yes, correct. It is size independent. The only morcellator with non-oscillating blade is the VersaCut. It works by back and forth, which is called guillotine-like action, guillotine miqsala. It's just like a guillotine-like action. It is not oscillating blade. To introduce the morcellator blade after successful complete prostate inoculation, use the same working element, use connecting bridge and long 26 French nephroscope through the outer sheath of the resectoscope, use the cystoscope, use the nephroscope sheath, and long 26 French nephroscope replacing the cystoscope sheath. Yes. Don't forget the connecting bridge. The connecting bridge in order to be able to introduce the long nephroscope into your outer sheath.
This is the best answer, but unfortunately sometimes you don't have this connecting bridge, and then you have to go to the next best, which is take everything out and then go inside with the nephroscope with the outer sheath of the nephroscope. But we don't like to do that, because after prostate surgery you don't want to come out and then go in and come out and then go in. So the best is to keep using the outer sheath, the 26 French continuous flow resectoscope, and to adapt the nephroscope by this connecting bridge. This is the best. But sometimes you don't have this connecting piece, so in that scenario you have to take out everything and go with the last answer, which is 4. Use the nephroscope sheath along 26 French nephroscope replacing resectoscope sheath. Yes, morcelloscope is, it's from Wolf. They use it to do the same job on their own set. Same set.
As regards HOLEP, which of the following is true? Postoperative ejaculatory dysfunction is 37%. It is not safe in patients on ongoing blood thinners, first described in Germany by Maderspracher, or the 10-year retreatment free rates is 95%. Yes, the correct answer is the 10-year retreatment free rates approaches 95%. For sexually active men, counseling prior to HOLIB entails erectile function will be at least the same. Ejaculatory dysfunction is highly probable. Orgasm is maintained. Erectile function will be better. Ejaculatory dysfunction is infrequent. Orgasm is maintained. Erectile function will be lost. Ejaculatory dysfunction is a must. Or the erectile function will be at least the same. Force of ejaculation will be less with maintained volume, and orgasm is better.
So welcome to Professor Adel Nabi. He will enrich our course by being with us today to moderate the first session of live surgery. Welcome, Dr. Adel.
So your answer is the first one, of course. The erectile function, HOLIB has no negative impact on the erectile function. However, the ejaculatory dysfunction, the incidence of new onset ejaculatory dysfunction after HOLIB reaches 77.3%. Okay. In patients with coagulopathy, laser-assisted prostate ejaculation is superior pi. Definite coagulation effect better than bipolar electrical energy. The definite coagulation effect better than monopolar electrical energy. No residual tissue and feasibility of controlling the bleeder once at entry or deep optical penetration is a hallmark for holmium laser. Regarding the laser-assisted prostate ejaculation in patients with coagulopathy, when you perform the coagulation with laser is better than bipolar. The ejaculation with laser is better than monopolar. The hallmark is that there is no residual tissue and you can control the bleeder at its site of entry, or the HOLIB laser has the deep optical penetration depth. Yes, of course, as you saw in the OR yesterday, as you inoculate the adenoma, you can reach the point of entry of the perforator and you can easily control so long you already inoculated the adenoma. Following completed successful laser-assisted prostate inoculation, morcellator stopped working. The next step is suprapubic mini laparotomy and adenoma extraction. Schedule a second session for morcellation. Incompletely detach the adenoma and proceed with the mushroom technique, or all are potential options. Yes, all options.
And the second session morcellation, if you schedule a second session morcellation, in certain case scenarios, if you have a large giant adenoma and you spent a lot of time doing the transurethral inoculation, and at the end of the day, the morcellator stopped working, and you don't want to incise to cut a patient, your patient is not accepting. If you accept a second session morcellation, it will be a very nice, efficient second session. Because if you leave the adenoma inside for 3 to 5 days, and then you come again, you can manage in 5 to 10 minutes with morcellation efficiency up to 25 grams per minute, because the adenoma over time gets softer and get easier to be morcellated by the morcellator.
Shrinks.
So it's good option if your patient will accept a very short second session instead of cutting or doing a suprapubic mini laparotomy.
Pulsed 2 micrometer wavelength laser is useful for prostate inoculation by less charring effect, constant steam bubble at the tip of the fiber, expanding steam bubble at the tip of the fiber disrupting the tissue planes, more vaporization with less carbonization. Yes, as we mentioned yesterday, the holmium acts by creating the air bubble, the water vapor bubble, at expanding bubble at the tip that makes it a dissector. It can create the plane between the adenoma and the capsule. TFL has the advantage over holmium YAG being has a water cooling system, has a higher frequency range, hardly portable machine, uses flash lamp as the excitation source, had less water absorption coefficient. Has a water cooling system, higher frequency range, hardly portable machine, uses a flash lamp as the excitation source, and the last one has less water absorption coefficient. I think the last one correlates to the first question. I told you that he has 4 times greater absorption coefficient compared to the holmium. So the last one is incorrect. It uses flash lamp as the excitation source. No, it is a diode pumped laser energy. The diode is the excitation source. It's hardly portable. No, it's quite smaller. It's a portable machine. Yes, much smaller in weight and size. Has a water cooling system? No, it depends on marwaha, fan. The cooling system is just a fan. So it has, of course, higher range of frequency that can reach up to 2000 hertz. The most important assuring cystoscopic finding at the end of laser-assisted enucleation of the prostate is capsule-free perforation, lack of residual adenomatous nodules, intact sphincteric ring covered by mucosal veil, or adequate hemostasis. And all are correct, but the most important is you must have an intact sphincteric ring covered by mucosal veil in order to keep the patient's continent. And such a nice view is after one of our surgeries. The mucosa, the sphincter itself is intact, with the covering mucosa also intact, and the patient is 100% continent immediately after removal of the catheter. During Holy Blurring, the transient early post-operative stress urinary incontinence can be attributed to the bladder dysfunction, laser-inflicted injury to the sphincter, stretch injury of the sphincter and stripping of the perisphincteric mucosa, perisphincteric urine extravasation. Stretch injury, yes, as published in literature, the stretch of the sphincter is the main cause of post-operative stress urinary incontinence. Conditions for safe morcellation include adequate visibility, keep the morcellator just inside the bladder neck, always keep the bladder full, upfront meticulous hemostasis. Yes, all must be present in order to have a safe morcellation. Don't forget the 2 black windows. Don't forget to withdraw your morcellator plate a little bit above to be inside the bladder cavity, and a little bit backward to be just close to the bladder neck. For rapid plateauing of the Holy Blurring curve, the most important factor is dense case volume, small prostate size to start with, watching expert videos, using simulators for pre-operative training. The most important for plateauing is you should have, yes, no, dense case volume, yes, you must have repeated sessions in a shorter period of time. This escalates your expertise and helps you to rapidly reach the plateau in the learning curve. Dense case volume. At the end of morcellation, small adenomas were hardly catchable, so reduce the rate of oscillation, reduce the flow of irrigation, grasp the adenoma to the prostatic fossa, use a loop to grasp them out. All are true. Yeah, all are true. You should reduce the rate in order to, we can say, reduce the retrobulging of the adenoma. And in the same manner, you can to somehow lessen the flow of irrigation. You can grasp the adenoma to the prostatic fossa in order to decrease the cavity, and so the adenoma has no place to escape so long you are performing the morcellation inside the prostatic fossa. And we have the serrated loop that can be used, the giant serrated loop that can be used to grasp the adenoma and extract everything out as one piece. The crown loop. During morcellation, the visibility is poor, with no obvious bleeder, despite repeated trials for hemostasis. The best is or are, yani what are the available options? Exploration, the visibility is not that adequate, but there is no bleeder, and you kept trying to perform hemostasis, but there is still an issue. So you should explore, put a suprapubic tube, put a urethral catheter and apply traction for 10 minutes and retry, or schedule another session for morcellation. Correct, 3 is correct, and 4 is correct. Both are correct. Both are correct. You can put the catheter, inflate the balloon, apply traction for only 10 minutes. These are usually venous bleeding, venous bleeders that can stop by the compression of the balloon of the catheter, and you can re-enter and achieve adequate hemostasis and proceed with your morcellation. Or if this is not applicable, you can schedule another session of morcellation. For prostate inoculation, holmium laser is useful for hemostasis, not if due to the low energy defocused beam, high energy contact mode, low energy high frequency effect, low energy contact mode. Yes, the low energy defocused beam. The low energy defocused beam with a small optical depth of penetration, it can achieve good hemostasis. The whitening effect you saw yesterday in the OR. Before you start your HOLIP, prepare your laser fiber as follows. Check the full moon sign. Strip the cladding for 1 centimeter. Ensure hassle-free way for the fiber. Never to manipulate the fiber after laser activation. This is for any laser. For any laser, for the prostate, for the stones, you should ensure all these parameters are checked well. So all the above. So let's come with the numbers. Following HOLIP, mean BSA reduction is reported to be as high as, yes, 87%. 87%. As we mentioned yesterday, one of the pentafecta was the efficacy, and the efficacy can be proven clinically, laboratory, cystoscopic, and imaging. Laboratory, by the evidence of reduced BSA after HOLIP to 87% of the original BSA. Compared to other morcellators, the oscillating blade morcellator has less running cost, lower safety profile, higher running cost, lower safety profile, less running cost and better safety profile, higher running cost and better safety profile. Other thoughts? Oscillating blade morcellator is much better than VersaCut, the guillotine-like action, so it has a better safety profile. It has a better safety profile. We agree on that. What about the cost? Less running cost. It has less running cost and better safety profile compared to the VersaCut. The VersaCut was the initial one. It was quite costly, but with the familiarity with the procedure and the expansion of the market, the cost of the oscillating blade morcellator is much less compared to the VersaCut. So we finished. Check your correct answer. If you got 16 or more, so you are master of a HOLIP, at least on the theoretical level, you know. Okay. Thank you. We've confronted with such scenario many times. You leave the catheter after 6 or 12 hours. The fossa is totally bloodless, and the adenoma, once is inoculated, and pushed in the bladder, it is deprived from its blood supply. The adenoma actually shrinks and get more soft. And literally the second session morcellation ends in 10 minutes. We once had a 200 grams prostate, and after the enucleation, the morcellator stopped working. It is measured by MRI to be 200. We performed the morcellation in a second session just 24 hours later, and the size was 130. It lost 70 grams of its weight in. No? We will shift to the OR. Sure.
دكتورة سي اشتغل بالبولر كويس ماشي في الطايف مع شادي وتامر هو اللي شجعني ان انا اخليه يسافر عشان شادي وتامر اصحابه شادي هو رئيس الاسم
كويس. تامر بركات صح؟
ايه
تامر بركات؟
تامر سمير وشادي انت كنا لحقت الشادي شادي محترم اشتغل ترانسبلانتيشن هو ماسك في الموضوع ده في المستشفى بيعملوا زرع كل اسبوع
بس حضرتك تقدمه بس محمد مصطفى يقدم الهيستوري بتاع الفيرست كيس.
Good morning. Dr. Mohammed Mustafa will present the first case of bipolar enucleation of the prostate.
Good morning, everyone. My name is Mohammed Mustafa, resident of Urology at Urology and Nephrology Center, and I'm glad to present our first case for today. It's about a 59-year-old male patient. He is not smoker with no other special habits of medical importance. Patient complains of long-standing voiding and storage lots. He has irrelevant medical history with he is not known to be hypertensive or diabetic, no neurological diseases, and patient is not maintained on antiplatelets or anticoagulant drugs. He has no previous prostate surgeries or any pelvic surgeries. Patient has within average laboratory parameters, serum creatinine of 0.7 milligram per deciliter, hemoglobin of 15.7 gram per deciliter, platelet count of 207,000 per cubic centimeter, and INR of 1.1. By direct rectal examination, there is a moderate large prostate with benign feeling and good anal tone. IPSS revealed severe symptoms with a score of 29. PSA was 15 nanogram per ml, for which a truss-guided biopsy was performed and revealed a typically small acinar proliferation in 1 out of 12 cores. Ultrasonography revealed normal upper tract, estimated prostate size of 62 cubic centimeter, and PVR of 12 mil. His uroflowmetry showed obstructed and prolonged voiding pattern with a maximum flow rate of about 16 and average 6 mil per second. The voiding time is prolonged, approaching 1 minute, and total voided volume is 265. This is his flow curve. By pelvic MRI, the prostate volume was estimated to be about 63 cubic centimeters with greatest dimension 4.5 by 5 by 5.4 centimeters. And this is a video of his pelvic MRI. This patient is planned to be managed with in-block bipolar endoscopic enucleation of prostate. Thank you.
Dr. Muhammad, what about Birat?
The BIRADS, the nodules at the MRI are all of BIRADS 2 lesions. There is no suspicious lesions by pelvic MRI.
What?
Two, BIRADS 2.
Two. Thank you very much. We shift to the OR. Any question? What is the value of BIRADS? If you have BIRADS 3, what can you do? Follow up or biopsy? If BIRADS 3, follow up or biopsy? Biopsy. In this volume, 60 gram, do you prefer resection or inoculation? Resection or inoculation? So you can do resection or inoculation according to the experience of the surgeon. If you have experience in inoculation, it is better. If you don't, you can do resection up to 80 gram. Do you prefer bipolar or monopolar? Why? TR syndrome. And the good hemostasis by bipolar. Do you have any experience with vaporization of the prostate, laser vaporization? What is the important complication of this technique? The most. A lot of patients complaining of severe dysuria during ovulation. Why? After vaporization. A lot of patients complaining of dysuria and painful micturition. For a long time, what do you suggest? Sharing of the nerve endings due to sharing or burning of the nerve endings. And a lot of patients complaining of this complication.
مفيش حرارة. مفيش حرارة من امبارح
ليه؟
في المركز كله، مش عارفة والله.
دفعناش